Today we will deal about an important topic, that is hyponatremia related. So hyponatremia related things, in which we are going to discuss why the time limit of 48 hours is important to divide it into acute and chronic hyponatremia, and we will deal the mechanism of osmotic demyelination syndrome. At the end, we will discuss how to correct hyponatremia, a practical approach to correction. So first is about the importance of 48 hours. So for this, a schematic diagram showing blood vessel and brain parenchyma. Blood vessel and brain parenchyma. So we'll consider these two. As we all know, sodium will be in this one, and there are various neurons in the brain tissue. So when there is fall in sodium levels, there will be dilution in this vascular compartment. So for this dilution to compensate, slowly some osmolytes from the neuronal cells start leaking out, mainly creatine, taurine, glutamate, etc. So these osmolytes will start leaking out of cells into the vascular compartment to balance the decreased osmolarity in the vascular status. Meanwhile, this diluted compartment will lead to shift of fluid into the neuronal cells. So this exchange will try to compensate. So this important shift over will occur when hyponatremia lasts for more than 48 hours, which in turn leads to subtle gait and cognition defects. Because neurons are losing important osmolytes and they are unwantedly gaining excessive fluid. Later on, if this continues for a few more hours, this might lead to nausea, headache, vomiting, etc. And it might even lead to coma also. So this is the importance of 48 hours. So all these changes will occur only if hyponatremia persists for more than 48 hours. So we consider it as acute if it is less than 48 hours, and if it is chronic, that is, if all these changes are probably have occurred, we will consider it as chronic hyponatremia. Now, why is it so important? Because this will help in understanding osmotic demyelination syndrome concept. Osmotic demyelination syndrome. So when there is chronic hyponatremia, that is, all these changes have already occurred, but we are correcting the sodium very rapidly, and rapid correction of sodium is occurring. That is what we are supplementing sodium iatrogenically. So now sodium levels will increase here. But the problem is, whatever the osmolytes have got shifted already, these osmolytes will not go back that rapidly into the neuronal cells. And this fluid and osmolytes imbalance will also damage the blood-brain barrier. So this will give a path for immune cells to enter brain parenchyma that will target oligodendrocytes, leading to demyelination. This mechanism is very, very common at pons. That's why it is also named as pontine demyelination syndrome. But the same mechanism can also occur at other sites, such as cerebellum, even thalamus, putamen, even brain cortex, cerebral cortex. So if the same mechanism is occurring at these sites, it is called as extrapontine myelinolysis. Dangerous situation to handle. So we have to be very, very careful in this osmotic demyelination syndrome. Just to revise it rapidly, when the hyponatremia is lasting for more than 48 hours, that is chronic, that is already osmolytes have got shifted and fluid has shifted into the neuronal cells, and we are giving rapid correction of sodium. At the end, it is resulting in excessive electrolytes, osmolarity, and osmolytes inside the vascular compartment. That will further lead to damage of the oligodendrocytes, and this fluid and osmolytes imbalance will lead to disruption of blood-brain barrier, which will give a entry for immune cells, again which will target oligodendrocytes, overall leading to demyelination, and the site where it is very common is pons. Other sites will be cerebellum, thalamus, putamen, even the cerebral cortex, which is called as extrapontine myelinolysis. That's why it is very, very important to correct sodium in right manner. So now we will discuss correction of hyponatremia. Again, we will consider acute first. So here we can be aggressive in correcting hyponatremia. So we can correct up to 1 to 2 milliequivalents of sodium every hour for about 4 to 6 milliequivalents. So this we can do rapidly. So when we are doing this using 3% NaCl, which we get 100 ml bottles, so we can give it over 30 minutes to 1 hour initially, and we have to repeatedly look for serum sodium levels like every 2 hourly until we get increase of sodium by 1 to 2 milliequivalent per hour. Up to 4 to 6 milliequivalents can be corrected rapidly. This is an acute condition. Whereas in chronic, as we discussed about osmotic demyelination, we have to be slow when we are dealing chronic hyponatremia. So here, slow correction should target such that only about 8 to 10, actually less than 8 to 10 milliequivalents of sodium level should be corrected in 24 hours. So here, same 3% NaCl, 100 ml should be infused over 4 to 6 hours infusion, and at least twice we have to check for sodium levels in a day, and we have to make sure that it is not overcorrected to prevent osmotic demyelination syndrome. And finally, one point we have to remember is that ODS is common, especially if the individual is alcoholic or malnourished, or if there is associated hypokalemia. So in these situations, if presented as chronic hyponatremia, we have to be careful with regards to osmotic demyelination syndrome. Hope you got the point. Thank you.